Hi, everybody. Thank you so much for inviting me today. We really hope to bring home everything we heard today. Great innovation, great technology. Let's make sure it's real for our patients, like we heard around listening to our patient. That's really what I want to talk about, too. I needed just a couple of questions. Patient-centered medical home. When I say that, PCMH, does that resonate with anybody in this room? Because it's going to make a difference on how I speak. So raise your hand. Have you worked in a PCMH model? Do you know what I mean when I say PCMH? Some of you. Okay. All right, so I'll back up a little bit so I can explain what that means. But I'm happy to be here. All right, so we're going to talk a little bit about how patient-centered medical home, meaningful use, it can be ACO. These standards can be used as a building block for your analytics team to build a foundation for population health management and value-based systems. Are you guys all ready for that? Yeah, right? Woo! It's a lot. Are you really ready to have somebody looking at your quality measures and being able to segregate these populations? So this is what we really want to get to. Do you know how to do it? What are you going to use to do it? How are your IT team and your clinical folk going to work together? I love it. It's my favorite thing to do. Okay, so we have some ideas, and we also have some case studies that I've been involved in Western New York. I am from Buffalo, New York. So I'm looking forward to, throughout this conversation, learning more about California and what you're working on. So I'm going to ask some questions. I did a little bit of research before I came, but I'd like to know more. So we have two big case studies that we did in Western New York that really helped lay this model out, and we're going to tell you that. And then we have an assessment tool that might help you all to determine how your organization's readiness is. Okay, here we go. We're hoping that you'll see the foundational elements of PCMH and meaningful use can be used as building blocks to build your population health management program. And I'll tell you about PCMH, so if you don't know it, you'll catch on. I know you will. You're all smart people. How do you identify those high-risk patients? How do you stratify them? I've had some wonderful recent interactions with people with an organization called Evergreen Health. We're going to talk a lot about. They are the HIV Center in Buffalo. And boy, did I learn a lot about vulnerable populations when you're dealing with the HIV population. So that's what I really want to talk about. They do some fabulous things that I've never seen done in other healthcare systems. And I've implemented PCMH over 40 medical practices throughout the country, and Evergreen's unique. So I want to give their message to you. And then how can community resources be used to help you? And then, of course, your self-assessment. Okay, the next slide, we'll skip this. I'm sorry that I did have a co-presenter, and she had an emergency and couldn't be here today. And she was the vice president of Evergreen Health. So I'm sorry, it was just one of those very unfortunate things. I have been with her for the last 6 months in Evergreen Health as a consultant. So I feel comfortable speaking on behalf of this wonderful organization. So I read, preparing for this, that California's been involved with DSRIP for a long time. Does that make anybody in this room groan at all or moan? You mentioned, do you know what DSRIP means? Anybody? DSRIP? Couple. DSRIP is Delivery System Reform Incentive Payment Program. And it's a big federal grant worth billions and billions of dollars. And the states all have the right to participate with DSRIP. California has had a project going for, I think, 4 or 5 years, right? Yeah. And it's, when I read, it was through the universities, seemed like. Do I get it right? Western New York and New York State has just started their DSRIP quest. April 1st was year 1 DSRIP. So I'm involved with that. It's an amazing project that gets to these vulnerable populations and these Medicaid populations. They want to know how you can get into the cracks of Medicaid. How can you get to those people that have never been involved in healthcare? How can you do this to them? So very innovative ideas are coming out. I read some good results that you guys had around telemedicine and decreasing ER rates at Irvine. So interesting work. That's what we're going to talk about. DSRIP in Western New York is driving a lot of money. That's driving some really great ideas. SNAPCAP is an organization of safety net organizations. Safety net are those people, federal designation for the Medicaid people, the Medicaid offices, okay? SNAPCAP is a representative of those 25 in Western New York. And then Evergreen. So these are the three things you're going to hear me talking about. Look at all that crap. Really, right? Look at all that. How can we survive that? We have DISRIP. Well, those who have been involved at DISRIP, it's huge. Western New York has 11 projects that involves 400,000 patients. I mean, they're big projects. Quality, ICD-10, Meaningful Use 1, Meaningful Use 2. Now we get to say they're all 2 and 3, right? We can't say 1 and 2 anymore. PQRS, patient portals, BIs, population health, shared care plans, blah, 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 blah. This is a lot of stuff. So how in your organization do you know where to go? How do you prioritize all of this? This is all work that needs to be done. As informatics, you have to be at this table. How do you do this? So this is what we're going to talk about. I would like to suggest one way to build your population health management program is PCMH and Meaningful Use as a starting point. Now, I'm not advocating, PCMH is from National Center for Quality Assurance. It's a recognition program. Now, there's other ones out there. ACP has one, there's an ACO one, there's others. But I'm a certified content expert with PCMH, and I saw in your DISRIP projects that in order to participate, you had to be PCMH certified. So this is out in California also. It is a national program throughout all the states. What PCMH is, well, I'm going to get back to that. So PCMH Meaningful Use is a foundation together with your community. What do you have that integrates your community? Western New York, I'm going to talk more about, has a really fabulous HIE that goes above and beyond the small systems and actually integrates the whole community. It's made a key difference. SNAPCAP is the organizations for Medicaid, DISRIP. Hopefully, all will improve your house to improve quality outcomes for the community. So I'm really talking at the community level here. I heard somebody from Department of Health. Is that person still here? Oh, there you go, yeah. So this is really talking about that population and how we can affect health on the bigger scale. Okay. So this square over here on the left is what PCMH is about. Access to care, same-day access. It's about the patients. It's patient-focused care. If I want to be seen today, I'm going to be seen today. And I don't have to prove I'm sick enough. Oh, my God. How many times do you guys go to the office and somebody says, really, are you sick enough to be seen? Right? How long have you had that? Pneumonia. You know, come on. If I want to be seen, I'm a patient. I get to be seen. I get to be seen. And not only do I get to be seen, I get to be seen at the time I want to be seen. If I want a 7 o'clock appointment, there should be 7 o'clock appointments. So that's what PCMH drives this down. It's all about access. Our patients need access. Care coordination, high-risk population stratification, population health management, patient engagement. So those are big clinical pieces, right? The other side is the meaningful use. EHRs, HIE, technology enhancements, BI analytics. And oops, sorry, I backed up one slide. There you go. I'm suggesting that PCMH and Meaningful Use can be used to combine these. I'm used to walking around, so I'm having a hard time staying still. What did we hear? I think we heard it over and over and over again. The technology folks have to be at the table with the clinical folks. There is no separating them anymore. That's what Meaningful Use is. It's about bringing them together. Because these big projects on the left need you. Oh my God, like I need you guys. Don't leave me. I absolutely need you to make this real because I have to figure out how to stratify those populations. And you have the ability to do it. So that's what I'm saying. This is a way that we can start building that foundation using these standards. Again, more of the same kind of thing. Patient-centered access, team-based care. Patient-centered medical home talks about continuity of care. You know, continuity where you see the same patient all the time, or you build teams. This is really an important concept. I was working at a consultant at a university-based system that had residents. Every 4 hours a week, the residents were in the clinic. So every day you had a different group of residents. How the heck do you do continuity in that model? And who are they serving? They're serving this Medicaid population that already feels isolated. They had no sense of a physician. They came in, they saw whatever resident happened to be there that day. They couldn't know their name, probably couldn't pronounce it. It was a really difficult model. So with patient-centered medical home, we had to fix that. So we had people around the table. We had IT people, nurses, doctors. How do we fix this? How do we get residents to see patients, the same ones all the time? And we did fix it. We developed these really fabulous teams. And you know what happened a year later? The University of Buffalo, State University of New York, changed their residency academic program so that the residents are now at the sites 5 days a week, every 5 weeks, instead of 4 hours a week, every week. So this is really powerful. We were able to change. I mean, State University of New York is probably like California. You don't get to change those things very often. And because we saw improvements in care, improvement in continuity, better patient satisfaction, we actually motivated an academic center to change their medical school policy. So I was really excited about that. Meaningful use, you all know this. This is the technology side of the house. I'm suggesting that these two groups should be sitting at the same table because they play off each other. Care management, care support, patient engagement, patient portal, right? I mean, we have to, in order to meet our regulatory items, let's make sure that they also meet our quality items on the other side. Does this make sense? All right. Healthy Link is the Western New York HIE, and I have to say, they really make the difference. We had this wonderful group of technologists that got from all the different hospital systems, and they came together and they were above the competitiveness. And they said, as a community, we need to exchange information. And we need to do this because, you know what, our patients are going to jump. So how many of your patients, I understand that you have a lot of localized HIEs. So what happens when the patient decides he wants to go to a different system? Then you can't get the data, right? Is that what happens in California? Help me. Yeah, so a localized, untethered HIE is a cool idea, and it's really, really working. It makes the difference. You can bring technology right to the patient side and get point of care, up-to-date information. So we're going to talk more about that. They ran a big project, and their goals were to obviously improve technology in Western New York, so they had a big chunk of money to buy EMRs. And they hired CTG and myself to transform their practices. So we went about installing over 100 systems in a couple-year period. But they took it one step further. They said not only do you need to install this system, but you have to also incorporate PCMH principles, which are patient-focused, continuity, care coordination. So we took these practices from paper all the way through to quality measurements and quality improvements. That's a huge leap in a 2-year period. So I'm going to tell you a little bit more about that. That's why PCMH works. Just in case you don't know where Western New York is, it's that group that's not associated with New York State. We're over 500 miles from New York City, and I really like to keep it that way. Yeah. I only go to New York twice a year to see a Broadway show or something. It's on Lake Erie. It's around Buffalo, Niagara Falls area, Lake Erie, Lake Ontario. And it's an old industrial town like a Detroit. So there's a lot of Medicaid, a lot of refugees. It's a very interesting place to grow up. This is Healthy Link. All of the hospitals in Western New York are involved with Healthy Link. All of them transmit data. Most pharmacies, all the radiology center, and most of the labs. So as a provider in Western New York, you can really see the full continuum of care on your patients. Because they did step up. And they also got the national grant for NHIN for the veterans. I heard we were talking about VA and getting information for veterans across the state? It does happen. HealthyLink has the grant and pushes data for veterans across the whole nation through the National Health Information Network, the only one in the country that does. So it does work. Now, HealthyLink's not without some issues, but it also has a lot of successes. It has about 700,000 people have signed consents for their information to be consented. Now, you have to remember, Western New York is looking at about 1.2 million population, so this is a big percentage of it. All the hospitals, I already told you, all the labs. The problems is, you know, it's still outside of the EMR. Unless you have a direct interface, then your patients that you ordered, your data comes through. But you have to query out to the bigger Rio. It's outside of the EMR, and that's a problem. HL7, data inconsistency. So their data sources are all the hospitals, right? They're the sources of the data, who all send different HL7 messages. It's nasty stuff out there. And normalizing that data is really difficult. So that's still a big problem. Data analytics, they're just getting off the ground with that. That hourglass, I liked that. They're buying into that model and they're building analytics at the HIE level, which is really cool. They do have state connections to Medicaid. So if you need data from California on your Medicaid population of med history or immunization history, where do you go to get that? What? The state? So is there a website you go to or something? No? Okay. So this is another cool thing that HealthyLink does, is they do have direct connections to the state. What am I doing with my enter key here? All right, so one thing about Western New York is we don't have a lot of big systems like you do. A lot of little small practices, a lot of rural practices. So that means we have lots of EMRs. And that's what all of this number is on the left here, is all of the EMRs that now are interfaced with HealthyLink. And all those colors are all the different EMRs. I think there's a 20-some, 30-some, lots of different EMRs. We have a product, Western New York likes Medent. They do a lot of Medent, a lot of eClinical works, a lot of Allscripts. Few NextGen. So those are all the interfaces that are directly resulted from HealthyLink. And these are the queries where you can go out to the main system and query. So they can go out and look at Jeanette Ball and see everything that has happened to me in whatever date frame I put in, regardless of what provider I saw. This requires a patient consent one time for the community, though, so it's easy to get. So this has really helped us. Now, I don't know what you all have here, but I was trying to brainstorm of what are some ideas that you have in California instead of this robust HIE that obviously takes years to get off the ground. Do you utilize direct messaging? Do you have direct messaging? Do you use that between systems? So does it, no? No, everybody's nodding their head. You do? Yeah?
We use direct. We also are part of the CCC, which is the consortium for exchange data.
Oh, okay.
So we do exchange data.
And where are you from?
Kaiser.
Say that again, I'm sorry.
Kaiser?
Oh, Kaiser. I love Kaiser. I was involved with an innovative, idealized office design with Kaiser a few years ago with advanced access, and it was really a fun project. Yeah. So these were just some ideas. Direct messaging, do you guys know what I mean when I say direct messaging? Everybody's nodding their heads? It's a way to send data to discrete systems from one to the other. Okay, so how do you do all this? How do you make it happen? How do you get ready for population health management? Here are some ideas. Recently, we did an assessment of all those SNAP-CAP organizations. There's 25 in Western New York, and those are the FQHCs, the federally qualified health centers, the Medicaid shops, the urban hospital centers, the really complex, that really serve complex sites. So we figured out a way to do a rapid assessment, and these are tools that you can use within your own centers, and that's why I'm talking about it. Did a rapid assessment and used PCMH and Meaningful Use as the base of those assessments. Did a graph analysis, did some dashboards, and these are kind of what we got. Before we show you, I have to describe the dots. There's yellow, green, and red dots, And those aren't that a practice is doing bad or good. It was, what are the remediation work effort necessary to receive either PCMH 2014, which is their highest standard, or Meaningful Use Stage 2. And remember, these are safety net organizations, so high Medicaid, and these are really hard. PCMH 14 is really hard. It's not easy to do. But what was cool about this is we looked at each of the PCMH standards, each of the meaningful use objectives, but not only if a practice was achieving them, but why weren't they achieving it, or why were they? So if you look at the criteria on the other side, we looked at each one of these standards based on governance, technology, workflow, reporting, compliance, and audit. So that you can really, as a manager, you can really start to figure out why maybe something isn't working. So let's take access, because that one's kind of easy to talk about. Access is about, PCMH says you have to have same-day access. It's a must-pass. If you don't have it, you fail. You have to have same-day access for patients regardless of why they want an appointment. So do you have governance that supports that? Are there policies? Are there procedures? Are your leaders supportive of that? Or are they throwing roadblocks of, oh no, our doctors have to leave after 2 o'clock. I don't see any patients after 1:30. And if the moon's full, I never do a physical. Right? So these are real issues that you deal with. I only want to do 3 physicals a week. I only want 2 newborn babies because I can't do them, they're too big. Right? What else have I heard? Well, the patients are always late, so make sure my last appointment's at 1:30 because I don't want to wait. What does that do? I had a practice that did that. So the last appointment was at 1:30, but they triple booked it because those patients are always late. So what happened when the patient came for their 1:30 appointment and they sat in that chair till 4:30? They came later next time. So we have self-defeating patterns, and sometimes you have to take a critical look at that. Access is very passionate to people. Ooh, tell physicians they don't have control of their schedule, and you'll hear passion. But basically, an appointment is an appointment is an appointment. Who cares what it's for? 15 minutes, 30 minutes? You should be able to see a patient regardless of the reason in those appointments. So get rid of all your appointment types. It's one appointment, 15 or 30. All right, so that's my soapbox. So each one of these standards then were based against these multiple criteria. So as a manager, you can see, let's see, this care coordination, this is actually a practice that hadn't really gotten that whole care coordination deal off the ground yet. So you could see all those reds because they really need some help with that. But they had a little bit of governance that supported that. But they sure didn't have any technology. Their system didn't support it. They didn't have any shared care plans. Shared care plans. Are you guys using those? Anybody? Shared care plans. I know, they're scary. One person. We're going to be seeing more and more of these out there. Everybody out there, get ready for shared care plans. They're there. They're coming. So the technology didn't support it. The workflow sure didn't support it. And their reporting systems. And no audit. I found that a lot of these safety net organizations really weren't ready for audit. If they were in a hospital, they had compliance officers. But if they're outside in these little rural areas, audit, well, they had no idea. Well, wait a minute, I made some copies and put it in a notebook. Does that work? So they really needed a lot of help with audit. All right, so this was kind of the whole gamut. These were 11 of the organizations that would fit on the slide. FQHCs, hospital-based clinics, and you can see now at a community level where some of the issues were. And it helped us, as consultants working in this area, what can we do to help this community prepare for population management? You can see care coordination is a big problem. So we developed modules that helped with care coordination, had workflows, ideas, how to stratify populations. So that's where you can take this at a community level and really see where your issues are. Look at that. Look at that alphabet soup. Those are all the quality measures that physicians have to deal with at a visit. inpatient and outpatient. So it's really important to look at all these quality measures and develop some type of matrix that compares them, and you develop some commonality so you're not recreating the wheel. What? Now, wait a minute. Why is this happening? You know, I think it's this mouse. I'm not used to it. I think my hand is going over the mouse, and it's just the heat signature. I use my hands too much, I think. Okay. So that's what this is. It's just an example of a crosswalk between meaningful use, PCMH standards, and UDS is the FQHC quality measures. Do we have any FQHC, federally qualified centers here? We do. Do we have any in the room? No. They serve okay. So those are, the FQHCs have very rigorous quality measures that they have to meet. And a crosswalk like this really helps when you have everybody around the table do this. Take your quality measures, align them up, and find commonality so that you don't start from scratch. Okay, high-risk populations. How are you all, as clinical informatics people, going to figure out how to stratify your populations to find out those populations that need extra help, that need extra care, that are high risk, that are causing the system a lot of money? How are you going to do that? Also, stratification, low, medium, high. I can't stress this enough. I think people are missing this. The low, all those people running around with Fitbits, those are your low risk. But you know what? We need to keep them low. We need to keep them healthy. So let's use those Fitbit technology to motivate people, to keep people healthy. We can't forget prevention. So while we're all worrying about the diabetics and the renal failure and the heart failures and the blah, 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 don't forget about the healthy people, because we want to keep them healthy. Or those people that are in the middle that are still healthy, but they have some diabetes that's a little out of control. You know, we have to make sure to get people in those middle populations down to the low. And you have to think about things like demographics, zip codes, what's in their neighborhoods. It's not only about diseases. Yeah, make a list of diabetics. How are you going to fix it? How are you going to make them better? I had one center. I love to tell stories. I gotta walk. There's this, I think I have ADD. There's this inner city hospital. No. There's an inner city hospital that had these huge diabetic rates. Oh, thank you. And thank you. Can you hear me now? Oh, it's not on. It's on? Okay, can you hear me now? So they had these big university system. They had a lot of diabetics. It was a very, very poor part of Buffalo. And we know that 90% of the patients seen at this city hospital were within 6 zip codes of the university, of the hospital, right? So we needed to really look at those zip codes to see what was driving diabetic health. You know what we found out? Not one grocery store in 6 zip codes. So we tell people, eat produce, fresh meat, and guess what? No grocery store. Isn't that wild? There was 56 Sprint stores and 90-some fast food restaurants, but no grocery store. So it's not good enough to say we have diabetics and we're going to tell them all to get their EA1C down. We have to get into the populations and find out what their barriers are. And that's what PCMH makes you do, is look at barriers of care. It's not that a patient is non-compliant. If you don't learn anything from me today, please take that word non-compliant out of your vocabulary. Patients aren't non-compliant. They don't want to not be healthy, but they have barriers to success, in my opinion. So what did we do to try to increase our diabetic outcomes for this hospital? We put a farmer's market together, and they could pay with their Medicaid card. Wonderfully successful. Now it's busy every day, every Thursday and Saturday, actually. Another thing we found is nobody was getting their mammograms. Women in these zip codes weren't doing their mammograms. Why was that? Why do you think? What? No transportation. And a mistrust in general of the healthcare system. So the Buffalo Sabres bought a mammogram bus. And they took the mammograms bus to the faith-based organizations, and the community workers housed it and invited community women in to have their mammograms. Rates went up through the roof. So these are really examples of how you have to get into these communities and figure out what their barriers are. Wait till we hear about Evergreen. Talk about barriers. Okay, Evergreen Health. Like I told you, it's the HIV Center in Western New York. 85% of the patients with HIV are cared for at this center. Wonderful, wonderful place. But they deal with not only the HIV population, but the gay, lesbian, transgender population. And one of the things we had to work with is, as informatics, how about this? 16 genders. We had to figure out a way to get 16 genders into the system. Because it's not just male, female, it's male transitioning to female, female transitioning to male, cross-dressing, all kinds of things. It was a very, very interesting place. They have a harm reduction model. They're the first ones in New York State that have been approved by OASIS for a harm reduction model. So what this means is regardless of how these patients enter the system, we'll take them at that point. And we're going to give them multiple points of entry because, you know what? If you're homeless, you don't really care about that HIV medication. Right? So this is what they did. They opened up their community center wide open to the community. They serve 2 meals a day. So if you don't have food, come on in, we'll feed you. Oh, and while you're here, there's an alert that sends to the pharmacy if you haven't picked up your HIV medication. And that pharmacist runs down and says, here you go, take this. They have a 97% med adherence rate on HIV medication. And I think New York State's only 56%. I don't know what California is. So this is really, really huge. Using technology to drive these important vulnerable populations. They have a needle exchange program. If all you're ready to do is come in and get a clean needle, come on in. Come on in. Just give me your needle. I won't even ask your name. Here's a clean one. They have a bus that goes out to the shooting dens. I didn't even know these things existed. I'm a little yuppie girl from the country. And they hand out clean needles. Because it's about maybe when that person that's using those dirty needles is ready for Suboxone treatment, they know where to go. It's developing trust relationships, reducing harm wherever you can. Food, clothing, housing. They own apartments all over the city. Substance abuse services, primary care, of course, supportive housing. They have a drop-in center for STDs. If you got a little something going on, come on in and we'll trust you for gonorrhea or whatever you need. No questions asked, take them at go. So this is a pretty unique model, kind of cool. They also have all kinds of alternative visits for group people, like transgender classes, art therapy for the homeless. I know, it's so cool. Come on in, draw with me. And their dining room has linens, and it's not a soup kitchen. It's nice. So this is a very interesting model, one I really, really, really enjoyed learning, because they take barriers of care and remove them. While I was there, there was a girl that came in with her baby, and she was in tattered clothes. She had obviously just been beaten. And she said, I have nowhere to go, and I heard you'll help. Within an hour, that girl had housing that night in a halfway house. The baby had diapers. They both were fed. The baby was washed because the baby was dirty. So that woman was a heroin addict, and she's now in Suboxone therapy. So again, it's trust. These people need to trust. So very, very interesting population, very interesting place. Do you guys deal with these populations at all? Anybody? Yeah, pretty neat stuff. The transgender population is extremely vulnerable. They really need help to get over the societal norms, and they're very vulnerable, and they're slow to trust. Very slow to trust. Very cool place. Also, recently, over the last 5 years, Western New York's become a refugee center. People come into New York City, they feel overwhelmed, they feel like they can't succeed in that big city, so they migrate across the state where housing's cheaper and there's jobs. And Burmese is now the second highest spoken language in Western New York, Burmese. Yeah, from Burma. I had to look it up. Where's Burma? It's along Thailand and Cambodia, where there's been a lot of civil unrest. So Burmese population and these refugees, this center helps them with transition to the United States culture, and they're set up in all kinds of entrepreneurial. They're very entrepreneurial, and the West Side now has become just this wonderful hub of small businesses that the Burmese people are running. It's really cool stuff. Okay, how are we doing, guys? Getting tired? A couple more ideas that I had when I was out in these communities trying to do PCMH with them. We had Amish. Do you have Amish in California? Or is that kind of a Northeastern thing? Quakers. So these are people that decide to live fundamentally simple. They're very fundamental, biblical, very highly religious. They don't have electricity. They don't use cars. They don't use anything gasoline powered. And they have a huge rate of diabetes in this little small community. So we tried to figure out what was going on there, and we found one, they put honey in everything because it's their natural sweetener. And they were also, because they can their meat, because they don't have refrigeration, there was something with they were poisoning themselves with the canning processes. So we got into the Amish community and taught them a little bit more about sterilization. And we got a phone installed. One phone on a telephone pole, and there was one woman, they tend to have a lot of kids, and the one woman had like 17 kids. And the phone we put by her house, because she was always around, and she came and answered the phone for the community if we needed to get to somebody, because these people had like A1C rates of like 17 and 18. Like, yeah, and you would think they'd be like super healthy because they live out of a garden, right? But they had issues. So that was a very challenging population to get to because they didn't have telephones. And you could send them letters, but then they didn't send you letters back. And we also had problems with infants coming out of the hospital. Infant mortality was really high. So we had to work on that too. And we already talked about the urban population with the fast food. We already talked about CTG, like I said. We installed over 100 systems and did PCMH with over 45 practices. We took people from paper all the way through to their system implementation, all the way through to quality and high-risk stratification, that's a big leap for these guys. And we saw unbelievable changes in these populations. And I'll show you those in a minute. The transformation of removing paper from these practices, setting up templates that had quality-driven metrics right in them, so it was easy for them to succeed. Those made the difference. And as informatics, I think you guys do that all the time, right? Set up ways for physicians to accomplish their quality scoring. And they all got access to Healthy Link through the grant, too. It made a big difference, especially for the rural populations. I'm going to skip this. So these were the improvements that we saw. They're huge. This was after 2 years. Overall improvement in hemoglobin of 77.4% of hemoglobin rates. Yeah, aren't they great? LDLs came down 80%. Now, some of this is improved capture rates because of the HIE. Really, really, really remarkable. So that's what I'm saying. PCMH, are you getting the theme? PCMH and meaningful use technologies can really drive quality improvements. Okay, so are you ready? Governance. There has to be a governance in place. Without governance, everything fails. You have to have a vision-driven decision process, identify and define goals, manage expectations. Without this, how many times have you guys been in a project without governance and it falls apart? Assess your governance. Medical home, do you have a comprehensive approach for taking care of patients? Do you have structure in place for same-day access? You think that's easy. It's not so easy. There's a lot of barriers to that. What about care team members? It's not just physicians taking care of patients. It's nurses, pharmacists, nutritionists. It's a care team, and that's where those common care plans really come in, especially with places like Evergreen where you have social workers, behavioral health, drug addiction. You know, you better have some common care plans that you're all on the same page. Identify your high-risk patients, performance measurement, and quality improvements. And then the technology is can you stratify your populations? Can you do reporting? Do you have an HIE that you can tap into? These are all important ways to stratify those populations. Are you using clinical-based guidelines? Are they in your templates? Are they easy for providers to use? And last, the reports. Ew. This is where I need all you guys. Please help me get a report. We need to prove that we're doing a good job, or else we're not. Okay, so it's all about providing the right care using evidence-based guidelines, the right patients using EHR functionality, the right way, workflow and integration, and then you got to prove it. It's a good little consultant slide, isn't it?